Chairwoman. John Monroe here on behalf of the Certified Registered Nurse Anesthetist. I'm here to request introduction of RS 0469, authorizing independent practice authority and the prescription of drugs by a registered nurse anesthetist.
Thank you. Committee, any objections to this bill being a committee bill? Seeing none, all in favor of this bill being approved? Aye. Aye. It's been introduced. Thank you. Any other bill introductions? Okay. Good morning. Thank you, Doug. Committee, any objections to this bill being introduced as a committee bill? Seeing none, it's been introduced. Any other bill introductions for today? All right, seeing none, we're going to move on with our agenda. We're going to begin with a presentation on the Can-Care Ombudsman, and this is virtual. Technical difficulties, all right. I'm going to give them just 1 minute, and if we still have technical difficulties, we can move on to the second. The room is having technical difficulties. Okay, we are still having some technical issues, so we're going to go ahead, if it's all right. Kristen, are you in the room? Wonderful. A presentation on the Kansas Legislative Division of Post-Audit, Ottawa, Beverly, Osawatomie State Hospital Audit. I'll get my lips to work. Thank you so much, and welcome to committee.
Thank you, Madam Chair and members of the committee. As mentioned, my name is Kristen Ridinghouse. I'm the Deputy Post Auditor at Legislative Post Audit. I'm not sure how many of you are familiar with our office, so I'll just give a brief background, but we're similar to Legislative Research and Revisor staff in that we are actually your all's nonpartisan legislative staff. We're a little bit different in that we take our direction from a joint legislative committee. So the Post Audit Committee is the one who selects the topics that we audit, and in this case, myself and my colleague Matt, who will be presenting presumably next, both take direction from that committee. So I'll be talking to you today about the Osawatomie State Hospital audit that we did and released in December of 2024. So that audit had us look at whether or not Osawatomie State Hospital adequately ensures the safety and security of its staff. And to answer that question, we did kind of three big pieces of work. So that include looking at things they're doing with regard to physical security. So if you think of things like door locks and keys, and things like security alarms that staff carry with them. We also looked at personnel. So that includes things like staffing ratios, turnover and vacancy rates, and things like overtime. And then we also looked at management culture. So that would include things like policies and procedures, processes they have for communicating with staff, and then their responsiveness to reported incidents. So I know you all have a lot on your agenda today, and we're asked to keep this brief. So there's a lot of information in this report, so I'm going to kind of fly by at a high level, but would strongly encourage, if you're interested, there's much more detail in the report, And we're also more than happy to meet with you one-on-one if that's something that you would like to have a further conversation about. So with regard to that first area of physical security, we found a number of problems in this area. For example, we found that security staff, they are supposed to do patrols of the physical campus. We found that those patrols were incomplete and inadequate. We found that security staff did not have enough fire-trained staff to respond to campus fires, so they had not actually provided fire training for staff since March of 2024 at the time we did our work. They didn't require staff to carry personal safety alarms and then didn't check how long it took staff to respond to those alarms when they were triggered. We also found a number of issues with facilities staff key tracking. So we found that tracking wasn't complete or accurate. Osawatomie itself identified a number of stolen and missing keys or keys that had been lost. So again, there's a lot more details supporting each of these things. The second bucket of work that we did related to personnel, we did see that for the period we reviewed, it appeared that Osawatomie and the Adair Acute Care had enough nursing staff on their patient units to meet their minimum staffing requirements. But in order to do that, they had to rely on a large number of contract nursing staff and overtime to meet those minimum staffing requirements because of high turnover and vacancy rates. So for those of you, if you're following along with the report, or it's something you want to look at later, I would encourage looking at the figure on page 19, which is figure 1. It shows a breakdown essentially of the turnover rates and vacancy rates for the 3-year period that we reviewed for each major kind of position of staff. So mental health technicians were kind of leading in terms of both turnover rates and vacancy rates amongst all the different types of staff. So the problem with that is that relying on contract staff and overtime to fill those things increases state costs and increases risk to staff safety. And that's because contract staff are more expensive than state staff, and obviously overtime pay is more expensive than regular pay. And then when people are working large amounts of overtime, that can lead to human error and mistakes. And the third bucket that we looked at, dealing with the overall culture, again, we found a number of issues in this area. So we found that Osawatomie State Hospital's management hadn't set clear expectations for how safety and security processes should work. For example, they didn't have policies in some areas, and then in other areas, those policies didn't reflect their current practices. We also found that management didn't collect and use data to proactively identify and fix safety and security problems. So, for example, they told us they don't track the amount of overtime by staff member. They also didn't have a centralized system to track safety incidents and staff discipline. And then we found that when management became aware of problems, they didn't always adequately address them. So we looked at a number of kind of incidents that had been reported at the facility and found that management didn't always take disciplinary action when we would have expected them to. And then in other cases, when they did take disciplinary action, we don't think that it was appropriate to address the issue. So again, if you want to go through the report to look at the examples of these sorts of things, you can find those on pages 24 through 27 of the report. We did also do a survey of Osawatomie staff, both contract and state staff. They had mixed opinions about what the facility was doing to ensure their safety and security, but the results do suggest that current management may be making some improvements in these areas. So again, we have some figures that summarize those responses from staff on pages 28 and 29 of the report, and we do have the full answers to that survey in an appendix at the end. So the last thing that I would do to wrap up my presentation is just point out, because of the number of issues, we did make a number of recommendations to the hospital, and the hospital did provided a fairly comprehensive response to those recommendations and our findings, and that begins on page 30. So Madam Chair, I will take direction from you on whether or not you want to open it up to questions or if you want Matt to go and then take questions.
Kristen, could you just take a couple of moments to go through the recommendations?
Sure. Let's see. So our first recommendation was with regard to physical security issues that we found. We talked about or recommended that Osawatomie State Hospital management should develop and regularly review and update their policies. Again, this would address those issues with maybe inconsistencies or a lack of clarity from staff in terms of what they're expected to do with things like those physical patrols of the campus, keys, progressive discipline, those sorts of things. We also recommended that they review, update, and clarify existing policies for things like personal security alarms, communication of the safety assessment reports, and they have like a safety concerns form that was in policy but not being used. We also recommended that they develop data systems and like a tracking process to help inform them of, let's say, systemic issues. So that would include areas like the use of personal safety alarms that staff carry with them, things like overtime and disciplinary actions. We also recommended that they use that kind of newly created data set that they would be collecting to monitor those safety issues, so that they should have some sort of like oversight committees. It's a fairly large campus with a lot of staff. So a way that would help them identify things like patterns and trends in that data to recognize if they have, again, systemic problems that need to be addressed. And then to improve morale and the working conditions, we recommended that they work on communication and setting clear expectations. So to do that, we recommended that they develop processes to ensure that all staff are held to those expectations consistently. And those are the recommendations.
Thank you. In committee, you will see the response from KDADS and from the hospital at the end of this presentation. We have time for a couple of questions. Any questions? Yes, Senator Holscher.
Thank you, Madam Chair. Thank you so much for being here. You know, throughout this document, it does appear that there's been a lack of establishing a safe environment for patients and staff. Is it attributable in some regard to training of management or maybe turnover? I mean, obviously, if you're turning over different staff and management, then you don't have somebody consistently there to set up the expectations, or something else.
I think our sense, I would say, is more the latter, that there's probably a lot of this that's attributable to things like turnover. We did look at training, and for the sample that we looked at, we didn't actually find issues with that. So the people who were supposed to receive training did receive it and the amounts that they were supposed to receive. So I think turnover is a big part.
Additional questions, committee? Yes, Senator Petty.
Thank you for the report. And you know, I looked at I'm looking at the agency's response, and having served on the Bob Bethel committee, this is Osawati's issues are continual when it comes to employment, and they're not going to change. I mean, it's going to be it's a high demand area field, and it's also a location where it's hard to keep employees. So we're going to be dealing with this, but it looks like from the agency's responses that they have put in place a process and a system to look at this in a timely manner to address the safety issues. Would that be correct?
Yeah, we didn't look at what their actual planned changes are, but we do know, this is one of the things we talked to them about during the course of the audit, is what they've done to address issues with things like pay. So it sounds like maybe there hadn't been a lot of requests in the past, but I know in the last year or two, those are some things I think they've been coming to you all with some suggestions and thoughts on maybe how to help alleviate that part of the puzzle. Now, how you address things like where it's located, competition with other facilities, because there's a number of them that are surrounding that may have better pay, for example. Those are difficult problems to fix.
Thank you, committee, and we have a pretty full agenda. Thank you so much for being here with us, and we all are concerned about these concerns. And now, are we ready technically, gang? If we're not, all right. We're going to move on to Matt Etzel. Matt, thank you for being with us, and give us an audit on TANF.
Good morning, Madam Chair, members of the committee. Thanks for having me today. My name is Matt Etzel. I'm also with Legislative Post Audit. I'm going to be giving a fairly high-level overview of an audit that we did recently looking at the state's TANF program. This audit had two objectives. For the sake of time, I'm going to focus on our first objective, which was to determine how the percentage of TANF funding going directly to families has changed in recent years. So just a little bit of background before I get into our findings. As I'm sure the committee is aware, the TANF program, federal program created in '96 to provide financial assistance to needy families. In Kansas, DCF administers this program. Since around 2013, DCF has funded about 50 different programs with TANF block grants. Those include cash assistance, foster care services, a variety of different employment services. For the sake of this objective, though, what we really focused on was looking at that cash assistance that goes directly to families in need. A little bit more background on page 5 of the report. It's in 2015, the state enacted the HOPE Act, which we point out that this changed a few eligibility rules when it comes to TANF in terms of who is eligible and how long that they can be eligible to receive TANF benefits. So it reduced months of eligibility from 48 months to 36 months. And it also introduced a variety of new employment requirements, including a series of tiered penalties if those employment requirements are not met. So that was kind of the goal of, or kind of the point of our audit objective, was to determine how the amount of cash assistance going to families has changed since some of these eligibility rules with the HOPE Act went into effect in 2015. So to do that, we reviewed state financial reports from fiscal years 2009 to 2023. And what we ended up finding was that the percentage of federal block grants that goes directly to cash assistance in Kansas has decreased since 2009. You can see that in figure 1 on page 7 of the report. In this figure, the dark orange shaded, it's the second from the bottom, that represents the portion of federal block grants that is going to cash assistance. As you can see, in 2009, that was about 15% of total block grants. In 2023, it's down to about 9%. We do note that the total block grant amount has not changed. It's just that that funding is basically going elsewhere. So instead of going to cash assistance, we see more of that federal funding going to other TANF-related programs. Specifically, we note the foster care and preventative services increased during that same time from about 7% of block grant funding in 2009 to about 32% in 2023. So as we see the cash assistance decline, we see spending on other programs within the TANF program increase as well. What that means in terms of dollar values in cash assistance, I'm looking on figure 2 on page 8. So we found that since 2009, so in 2009, the state spent about $15.2 million of the federal block grants on cash assistance. That has decreased, corresponding to the figure 1, down to $9.4 million in 2023. But we wanted to drill into this number a little bit more in terms of why the decrease, what is going on there. What we ended up finding is that the average assistance to families has not changed. In recent years, it's stayed relatively consistent, on average between about $111 and $118 per month per family. So it's not necessarily that families are getting less cash assistance per month. What we ended up finding was that fewer families are receiving benefits at all. So we looked at caseloads, and you can see that on figure 3 on page 9. We ended up finding is that TANF caseloads have really decreased over the years. So in 2009, the state was averaging about 12,600 TANF cases. In 2023, that dropped down to about 2,900 cases. So again, it's not necessarily that families are receiving less money per month. What we ended up finding is just that fewer individuals overall are on the program, which has led to a corresponding decrease in the amount of cash assistance or the amount of the block grant that is dedicated to cash assistance. We do note there are a few different reasons why this might be the case. The decrease in caseloads does correspond, although we can't say definitively, it does correspond to changes that were made in terms of eligibility rules, looking at who can qualify for TANF and how long they can qualify for those. So there might be a corresponding effect between the decrease in caseloads and some of those eligibility changes that we saw back in 2013. That is a very high level, and to Kristen's point, there's a lot more information in this audit. I'd be happy to stand for any questions, but similarly, if there's anything else that I can talk to any of you individually about later on, please let me know.
Committee, are there questions for Matt? Senator Petty.
Thank you, Matt. One of the things you didn't mention, what would be the income, the monthly income that a family would have to be, already have to qualify for TANF?
So it varies across the state. It's based off of the county of residency. So there is a formula that prescribes that, but it is fairly low. The threshold is fairly low to qualify. I don't have the exact numbers in front of me now.
Yeah, I saw that for Topeka, it was very low. And so there's been a 77% decrease in those that were receiving TANF since 2009.
In caseloads, yes. On average caseloads, correct.
Thank you.
Senator Holster.
Thank you, Madam Chair. Thank you so much for being here. I'm looking at the chart on page 7 where it shows the breakout of the different areas, and it lumps together foster care and prevention services. Can you first tell me a little bit about what the prevention services, like what's in that?
They are related, so perhaps no one from DCF is here today, but the preventative services is really spending to try to keep families in with their parents. So it's preventing children being taken out of their home.
Okay, so it's, if I may follow up, so then, yeah, it's all part of that same process as far as foster care. Okay, and so then if I am understanding the chart correctly, then it sounds like some of the rules have changed in regard to TANF as far as eligibility. So we have fewer people who are able to take advantage of it. So that number has increased, but the investments we've had to make then in foster care have increased. I'm understanding that correctly.
That's correct, because those are, so instead of going to individual families, those are more program funding. So those portion of the block grant are going to fund various programs throughout the state, but it's not necessarily going to directly to individual families.
Thank you.
All right, committee, we're going to move on. Thank you so much, Matt, for being here, and they know how to reach out to you if they have additional questions.
Thank you.
Next, we're going to move to all right, we'll try that. We could resort to Morse code, but this might work a little bit better.
Good morning, everyone. Good morning, Madam Chair and Senate Committee. It's nice to be with you. I apologize for the apparent technical difficulties that we were having. I was in the waiting room and everything seemed to be fine, but it seems as though it wasn't going through, so I apologize for that. I also apologize that I can't be with you in person today. We are in the ks.gov Ombudsman office here. We are in the process of setting up a new satellite office, so that is what is happening with me this morning. But I appreciate the opportunity to join you and look forward to sharing a few comments with you, and I'll be happy to stand for questions as soon as I'm done speaking. I'll be brief, as I understand there isn't much time, so I hope all of you can hear me okay. And Elizabeth, thank you for the creativity in getting me through here. So again, my name is Suzanne Luker. I serve as the ks.gov Ombudsman for the state of Kansas. The ks.gov Ombudsman Office, I'm sure many of you do know the history of it. It used to be attached to KDADS, but became an independent agency through executive order a couple of years ago in 22 officially, I believe. And so the ks.gov Ombudsman Office, its primary role is to help individuals understand how to navigate the ks.gov system, and in doing so, assist in solving any problems or difficulties that they may encounter. We assist not only ks.gov members, also prospective ks.gov members, and sometimes providers have questions as well. Some of the things, just to give you an idea, some of the things that we assist with include, understanding letters from ks.gov that members receive in the mail, responding when a member disagrees with the decision or a change in coverage. Sometimes we'll assist even with completing an initial or renewal application. Oftentimes we will call a member, we will do a three-way call with the ks.gov clearinghouse to try to resolve any issues that they're having. And then sometimes members want to file a complaint or a grievance and or request a fair hearing. So, and then lastly, just assisting them in learning about in-home services, specifically through HCBS. We do sometimes get inquiries with regard to long-term care, but as you all know, we have a long-term care ombudsman for the state. So those questions are typically redirected unless they have something specifically to do with HCBS as well. The ks.gov Ombudsman Office generates quarterly and annual reports, and I believe Madam Chair, if I'm not mistaken, you're also chairing the Bethel Committee, and so you may recall some of the reports that I've put in within the past year, and so we try to do executive summaries quarterly and provide that information to the Bethel Committee, just to give everyone an idea of trends that we're seeing. So. For example, if we happen to be, we'll report our initial contacts. So we've had about an average of 771 contacts per quarter. And those are new contacts, by the way. So I'll report that. And then also, as I mentioned, trends. So, for example, we've seen an increase in IDD waiver questions, SED waiver questions, TA waiver questions, and that does ebb and flow per quarter as to what we're seeing an increase with. So we like to keep the legislature informed as to what's coming into our office. I'll go ahead and pause for a moment. Again, I know that our time is brief here. I do have one additional point I'd like to make, but I'll go ahead and pause and see if there are any questions from the committee.
I would say go ahead and make your point, and then we'll open it up for questions.
Yes, ma'am. So finally, I just want to mention one thing that our office has been working on in the past year is we are interested in creating kind of a ks.gov Ombudsman Ambassador program. We'd like to have additional outreach in each quadrant of the state. We have excellent representation throughout the eastern portion of the state, and we've been able to do great outreach throughout that eastern portion, but I'd really like to see us expand and be more representative throughout the western portion of the state. Recognizing the population centers are, of course, predominantly in the eastern part, and of course Sedgwick County as well. But we'd like to get out there and talk with folks in the western part of the state as well. So that's something that you'll continue to see us work on, and I hope to have some great information to share with not only the Senate committee if requested, but also, of course, the Bethel committee. And that concludes my comments. Thank you so much.
Thank you, Suzanne. Do we have questions for Suzanne Committee? Okay, Senator Clifford.
Thank you, Madam Chair. Suzanne, wondering if we've had an influx of questions regarding the new MCO arrangement. Has that started yet? Thank you.
Yes, Senator. I think if I understood your question correct, it was, have we had an influx of questions regarding the new MCO? Did I hear that correctly?
That's correct. Thanks.
Yes, Senator. We have had quite a few questions with regard to how the transition is happening. We haven't had an incredible amount of difficulties at this point. We have tried to connect members who were transitioning from Aetna to Healthy Blue. We've tried our best to connect them with the appropriate parties, and I will say that KDHE has done a very nice job of providing some informational brochures, sheets that we were able to pass along to members and or providers as they contact us for questions. So from our end, it has seemed to be fairly smooth so far, but there have been quite a few questions.
Thank you. Thanks, Madam Chair.
Suzanne, most of the questions that I get are regarding the DSNPs, which are, for those who don't know, the people who are dually eligible for Medicare and Medicaid special needs plans. And there seems to be no one in particular in Kansas for the department that can answer their questions. And most of them, of course, are signing up through the MCO, but that seems to be a different program. So if they have specific questions, they're told, well, contact the insurer or contact the state. Do you help with that?
We certainly can help with that. Yes, absolutely. And I would welcome any questions or concerns to come through the office. We would be more than happy to get them to the right place. We can't always, we do serve as somewhat of a liaison in our role, but we certainly can connect them, and we don't ever leave a member or provider hanging without an answer. So, please direct them to us, and we'll be happy to assist in getting them to the right place to have their questions answered.
Good to know. Thank you. Committee, other questions? Okay, seeing none. Thank you so much, Suzanne, and sorry for all the technical difficulties here today. I appreciate your patience. Now we will move to Kyle Kessler, and he's going to share with us about an update on the Association of Community Health Centers of Kansas. Just FYI, we usually don't have associations. There are so many of them to come forward because this organization is so closely affiliated with the departments that we thought it would be good to have an update. Kyle, welcome to committee.
Thank you, Madam Chair, members of the committee. I am Kyle Kessler, Executive Director at the Association of Community Mental Health Centers of Kansas. We appreciate the opportunity to be here this morning for a little bit to discuss some about what's happening in the CMHC system, some about the history of the Community Mental Health Center system, and as well as in a few minutes, I'll hand off to my colleague, Michelle Ponce, who really is one of our resident experts on the new model, which is the Certified Community Behavioral Health Clinic model. And again, as a reminder, our association represents all licensed 26 community mental health centers around the state. So, I mean, many of you have more than one mental health center in your district if you have multiple counties, but every county has a designated community mental health center. And in our written comments, it goes into a lot more of the history, and in the second page of our testimony, it goes into our statutory responsibilities. Specifically, I would point out Chapter 59 that deals with the Care and Treatment Act and the connection the community mental health centers have as the gatekeeper for the state mental health hospitals. And now the new state mental health hospital in Wichita, which we believe will not just be a real benefit to South Central Kansas, it be a game changer in all aspects for the patients, the families, the staff, but also have a residual effect on the Osawatomie State Hospital and Larned State Hospital as well, as they have been around, between those two mental health facilities, a waiting list of around 50 to 60 people the last several weeks. And so this will act as a relief valve for not just, again, those patients and families and the staff at those facilities, but also law enforcement, community hospitals, and other partners locally, obviously the community mental health centers who we represent. So I think that for that piece, you know, I would also point out that the Mental Health Reform Act, which was passed 35 years ago, and there were legends around this building who worked on that, ranging from Dr. Bob Harder to Pete McGill, Paul Klotz, people who, and then the bill was signed by then Governor Hayden. And that really set the tone for what a lot of other states started following, which was somebody has to have a responsibility for the inpatient admissions as well as the discharge for people with severe and persistent mental illness and people who are receiving inpatient treatment as part of state care. And so that has been something that has worked well in our system over the years and around the state. There are some mental health centers that have up to 20 counties that they're responsible for, that those, again, rural and frontier areas, and as many as, I know Senator Clifford, I think his mental health center has 13 counties that they're responsible for. And then Johnson County, there are a lot of single county mental health centers as well. I think 8 of them. So, I mean, there's a lot of variety throughout our system, but the connection with community government and communities themselves is extremely important. And as Chairwoman mentioned, our connection to so many pieces of government. We work on a weekly basis with the State Department for Aging and Disability Services, the Department for Children and Family Services, KDHE, the Department of Education. There's now mental health funding in the Department of Agriculture. And then you take into account the county governments, and I missed the Department of Corrections also, but then county governments and then the CCBHC model certainly has more connections to the federal government as well, and the Department for Health and Human Services, and a couple of different divisions under USDHHS. So we have a lot of government in our lives. And so, and then you take into account the additional connections that we have with other partners, whether that is in the child welfare system or the federally qualified health centers, which are partners at the local level. And I think that we're trying to do more work with them in terms of cross-references, cross-referrals. So they do some behavioral health, but really I think are focused on primary care. We're starting to do some additional primary care work, but really the behavioral health piece is our stock and trade. So those are the key points that I wanted to mention. Certainly, and Michelle may mention it, but the Kansas Behavioral Health Center of Excellence, which is a workforce initiative that we are at the table at, along with several other providers, as well as about half a dozen different education entities. That was something that really was spearheaded, and several of you were involved in that, and we appreciate your work on it last year. Late Chairman Les Mason was a key figure in that, and it actually had to do with the fact that we had contract nursing costs at Larned State Hospital that were 5 or 6 years ago around $5 million, and last year they had risen to nearly $50 million. That is an unsustainable path for our state. So part of what we wanted to do, and nursing is a big part of that, working with community colleges and technical colleges, we've got to grow our own, and we've got to show our workforce here in Kansas, not just at the secondary level, but if you are looking for a new career, we have an opportunity for you. If you are in high school and don't know what you want to do yet, and maybe you or someone in your family has seen a therapist and you haven't realized that maybe this is for me. A lot of people get into primary care because they ended up tearing up a knee in high school and then become a physical therapist, or have had other issues. And so why would behavioral health be any different than that? It's really an opportunity for us. So with that, I would stand for questions at the appropriate time, and you may want to hear from Michelle first and do a collective Q&A. It's up to you, Madam Chair.
Let's do that. Let's hear from Michelle first.
Absolutely. Thank you,
Thank you.
Good morning, Chair Gossage and members of the committee. I am Michelle Ponce. I'm the Associate Director at the Association of Community Mental Health Centers. What I want to talk to you about today are the changes that the transition we've had in the community mental health system over the past 3 years. First of all, everything Kyle mentioned about community mental health centers remains true. They must continue to meet state licensing requirements, and they retain all of their statutory and contractual obligations. They will also continue to provide all of the traditional community mental health center services that they provided prior to becoming certified behavioral health clinics. You can think of CCBHCs as a new provider type under Medicaid. It's a new model of care. It's an integrated model of care that requires them to go beyond those traditional mental health services and really ensure that all of their patients' needs are met, whether that is through primary care screenings and making sure they're getting appropriate care for any issues they may be having, or meeting social determinants of health, whether that's helping them gain employment, find housing. There are two main things that I want you to remember about the CCBHC model. First, it expands the service array to the community, and that's the most important piece. Second, it fundamentally changes the way that community mental health centers are reimbursed for Medicaid-funded services. It moves away from the traditional fee-for-service model to a prospective payment system. That prospective payment system is meant to reimburse them for the true cost of care, and they receive that heightened payment for Medicaid consumers. At the federal level, SAMHSA, or the Substance Abuse and Mental Health Services Administration, outlines what they call the CCBHC criteria. It's a list of 117 unique requirements that a CCBHC must meet. Those requirements cover 6 program areas, including staffing, accessibility of services, care coordination, the scope of services, quality reporting, and organizational authority and governance. I've outlined those 9 services for you on page 5 of our testimony. 2 that I want to call to your attention in particular are crisis services. The state must have a comprehensive crisis response system now as a CCBHC state. That includes 24/7 mobile crisis response. Under the CCBHC model, there is also a requirement for specific outreach to active duty military and veterans. So not that they weren't served under the CMHC model, but there's a very specific focus on ensuring that those individuals access care. The CCBHC model also requires states to implement evidence-based practices. It does leave some flexibility to the state to determine which EBPs they will implement. In Kansas, we've chosen 4. The first is ACT, or Assertive Community Treatment. You can kind of think of this as a team approach to intense case management services in the community. They're serving individuals with the highest level of needs. Often those are individuals who may be unhoused or who may be at risk of engagement with the criminal justice system due to their mental illness. The second is IPS, or Individual Placement Support. That is a supported employment program. That is helping to ensure that the patients that they are treating are supported to gain and maintain employment. The third is medication-assisted treatment. You'll hear us refer to that as MAT. It's the use of medications in conjunction with therapy to treat substance use disorder. And the fourth is cognitive behavioral therapy. Not considered an EBP, but as I mentioned, the state is required to have that comprehensive crisis response system. Your CCBHCs are the cornerstone of that in Kansas. They each continue to maintain their crisis hotlines that they've had for many years. They are also tied into 988, this National Suicide Prevention and Mental Health Crisis Hotline. When someone calls those crisis lines, the clinician answering the call will do their best to de-escalate the situation. But if that person determines that the individual that is in crisis really needs a higher level of response, they dispatch the mobile crisis teams from your local community mental health center / CCBHC. The expectation is that an in-person or face-to-face response is made within 2 hours. That's a requirement of all of our CCBHCs everywhere in Kansas. Part of the crisis response system also includes the crisis stabilization units that are operated by about half of our CCBHCs. That allows them to provide short-term inpatient level of care. Often that's 48 to 72 hours maximum. They're only able to take voluntary admissions at this time. However, the Kansas Legislature passed a bill in 2017 allowing for implementation of crisis intervention centers. Those regulations were finalized about a year ago, maybe a little less than that. And now we have several of our crisis stabilization units working to become crisis intervention centers. The primary difference there is that they are able to take involuntary admissions. Once they're able to do that, it is our hope that it will take a little bit of pressure off of the state hospital system by being able to provide some of that crisis stabilization within those patients' own communities where they're around their own support systems. The next thing I want to talk about is workforce. The entire state of Kansas is no surprise, or at least most of the state of Kansas is considered a healthcare professional shortage area. The new resources provided to our CCBHCs through that prospective payment system have been a game changer for our community mental health centers in terms of recruitment and retention of staff. Over the past 3 years, they have now been able to be more competitive employers, and we filled vacant positions such as case managers, therapists, and nursing and APRNs. We've been able to also retain them. That's important not only to the operations of the organization, but to the patients that they serve, because it allows for more continuity of care. When we hear for consumers, the number one complaint is, I constantly have a new therapist and I have to tell my story over and over again. The ability to retain those therapists and those case managers and provide that continuity to consumers is very, very important. Not only have they filled vacancy rates, they've reduced their turnover. I also want to talk just very briefly about the accountability that comes with becoming a CCBHC. Those same criteria outline a set of performance measures and quality outcomes that all CCBHCs must meet. Never before have we really had the ability to compare apples to apples, whether that's one CMHC in Kansas to another CMHC in Kansas, or a CMHC in Kansas to another mental health center across the country. Now with CCBHCs operating in 46 states and the same list of outcome measures, we'll be able to do that. One of the projects we have underway at our association is implementation of a statewide data warehouse. We will be collecting all of those required outcome measures. We hope to have all of our CCBHCs actively reporting data later this year, late summer, early fall. At that time, we'll be able to run reports and show you exactly how our Kansas CCBHCs are performing. Lastly, I want to say we're cautiously optimistic. We're seeing some really positive early outcomes on the last page of your testimony, and I won't read through them, but I provided for you a few success stories that are linked specifically to the new CCBHC services. If you have a little bit of time, please read through them. We have individuals who now have housing, who now have gainful employment, who are now looking to go back to college, who were unable to do so before they received the treatment from their CCBHCs. Those promising outcomes are in workforce and patient outcomes, but I just want to remind you, it's a big lift, and it's going to take some time to really move the needle on some of those big goals that we have, like reducing hospital inpatient admissions. So some of our CCBHCs haven't even been CCBHCs for 1 full year. So over the next couple of years, we hope that we'll continue to see additional improvements across the system, but it will take some time for our system to fully develop and mature. And with that, I'm happy to take any questions you may have.
Committee, we have a few minutes for questions. Do we have any questions for our CCBHCs? And just when I'm looking at time, probably we'll have time for about 3 questions, and I do have one, so we'll kind of rush through these for you. All right? Senator Clifford.
Thank you, Madam Chair. Kyle, I was wondering how the financing is going. Maybe Michelle, you can say as well as Ponce. Are the counties still supporting the CCBHCs now that they're in the prospective payment system?
Yes, to this point, all of the counties are still, and there's a statute that requires counties to help support their CMHCs, but it doesn't say to what extent. So that leaves a pretty, there's the floor, but it's a variance across the state. But so far, all of the counties, maybe a couple have cut a little bit here and there, but by and large, our message has been, our hope is this freezes you for the long term. Please don't give up, because if you end up supplanting funding, and the Medicaid population is again variable from county to county.
Thank you, Madam Chair.
I'll go ahead with my question now, Kyle. So it's come to my attention that a CCBHC, somebody comes to see you, they have private insurance. That private insurance is then billed, correct?
Correct.
All right. And then what percentage would you say, off the top of your head, is billed to Medicaid as opposed to billed to private insurance?
We're actually right in the middle of surveying our centers. With about half of my surveys in, it looks like about 40% of the patients that they see are covered by Medicaid. Again, that can vary pretty dramatically based on the area of the state and the Medicaid population. But probably in the 40-ish range. I hope to have some remainder of our responses in soon, and when we do, I'd be happy to send that to you.
By responses, you're saying you sent out a survey?
Yeah, we surveyed our members, all 26 of the CCBHCs.
All right, very good. By the way, this map is very helpful to see where they're located, because we do, as senators, get these requests of where would ours be?
Two quick things. One with that, we'll also provide a bigger map to the committee, which has a key for the numbers, so you know what the name of the ones in your area are. And secondly, with the number of private pay or self-pay folks, I mean, there's really 4 categories with the Medicaid, then private pay or self-pay, and then private and commercial insurance.
Very good. Committee, other questions? Great job. You obviously explained it very well.
Thank you, Madam Chair. Members.
Thank you. Committee, we are adjourned.